Great. Welcome, everybody. We're super excited today to have Pooyan Kazemian. He's an assistant professor jointly appointed in the School of Public Health and the Rady School of Management. Prior to joining UC San Diego in 2025, he was on the faculty at Case Western Reserve University's School of Management for 5 years, and before that at Harvard Medical School and Mass General Hospital for 4 years. His research lies at the intersection of artificial intelligence, machine learning, and data-driven optimization with a focus on improving healthcare delivery, population health, and health policy decision-making. He develops and applies advanced analytic methods to analyze care, optimize healthcare operations, reduce costs, and improve health outcomes for individuals with chronic and infectious diseases. And I'm excited to be a collaborator of his on a project funded by the CFAR. And so I think he's going to be talking about some of those initial results today. Puyen,
Thank
take
you
it
so
away.
much, Dr. Wilkin, for the introduction. And hi, everyone. It's great to be with you today and present my research on optimizing HIV care under budget constraints using optimization and machine learning. Before I get started, let me go over my disclosures quickly. So this research is supported by the San Diego CFAR developmental grant that I got earlier this year. I report no conflict of interest, and I would like to thank my co-authors, my mentor, Dr. Wilkin, on this grant, as well as Dr. Friedberg and Shinwen from Mass General Hospital and the entire CPAC modeling team. So my research objective today is to develop a framework for informing the best ways to allocate a limited budget among HIV testing, prevention, and treatment interventions to minimize HIV transmissions with near-term deaths as a secondary objective. And in order to do so, we develop a framework that combines microsimulation with optimization and machine learning. And we demonstrate this framework using a case study of the HIV program in South Africa. So let me tell you a little bit about the HIV epidemic in South Africa. South Africa carries the largest HIV epidemic in the world. 7.9 million people are living with HIV in that country, with 6.2 million of them receiving antiretroviral therapy or ART. Roughly 146,000 new infections are reported in South Africa, with 53,000 AIDS-related deaths every year. South Africa also happens to operate the world's largest HIV program and spends north of $1.8 billion annually on their HIV response. So with all the advancements in HIV testing, treatment, and prevention over the past decades, the question facing the program is no longer whether a given intervention works or not. The question is which combination of interventions to fund, at what intensity, in which populations, given the limited money that we have available. So let me clarify a terminology. So in this research, we call a specific combination of intervention levels a bundle or a bundle of care. Sometimes I also use solution or a strategy to refer to the same thing. So bundle, solution, or a strategy, they all refer to a specific combination of HIV interventions at different levels. So why finding the best bundle of care is difficult? Why do we even need new methods? Well, finding the best bundle of care is difficult for three reasons. The first is that the interventions are not independent. The prevention value of PrEP depends on how much onward transmission ART is already suppressing. And the yield of a testing program depends on how much PrEP the tested population is already using, because PrEP prevents the new infections that testing would otherwise find. So all of these interventions overlap in a sense. The second reason is that the number of candidate bundles grow multiplicatively. So consider 6 interventions at 5 levels each. That is already 5 to the power of 6 or over 15,000 bundles of care or 15,000 combinations of interventions. If we consider finer levels, for example, if we consider 10 levels per intervention, or if we want to model additional interventions, that can push the number of feasible combinations of interventions into millions or billions. And the third reason is that the existing budget is often fully committed, which means that any expansion in one intervention must be paid by cutting other interventions. And as we just discussed, cutting one intervention affects the value of the other interventions in the bundle of care because of the overlap and the interaction among these interventions. So for all of these reasons, finding the best way to allocate our limited budget among many different interventions is actually a very difficult research problem. So why standard modeling studies cannot answer this question? The standard tool for evaluating HIV strategies is microsimulation modeling. A microsimulation follows thousands or millions of simulated individuals, one person at a time, through infection, disease, treatment, and deaths. And given a fully specified strategy, a microsimulation can project new transmissions, deaths, service volumes, and cost with a level of clinical detail that no simpler model can match. However, microsimulation models evaluate a given strategy. Microsimulation cannot search for a better strategy. This is because of the nature of simulation modeling, which is essentially a predictive model, not a prescriptive model. And as we mentioned on the previous slide, the number of candidate bundles can also be in the order of millions or billions. And evaluating all of them one by one using a microsimulation model can be extremely computationally intensive and essentially impractical. Also, most HIV modeling studies compare a handful of predefined strategies, and they essentially vary one intervention at a time around a base case and report the best strategy. Therefore, the strategy that they report is essentially the best among the very few strategies that the analyst chose to model. Uh, there is also a second gap, which I believe is even more important than the previous one, and that is the fact that nearly every modeling study in the literature reports a single best allocation. However, HIV transmissions can be averted through more than one causal pathway. For example, we can avert transmissions with ART. ART can reduce the infectiousness of people living with HIV. We can also avert transmissions using PrEP. PrEP can reduce the susceptibility of people who are not infected. So you see, there are more than one way that we can avert a single HIV transmission. And as a result, there is usually more than one bundle of care or one combination of interventions that result in almost the same number of transmissions. We actually show that many bundles that look very different can perform almost identically, and therefore reporting only one of them as the optimal strategy is going to be misleading. Also, projected outcomes carry a stochastic and parameter uncertainty, and therefore, two bundles whose projected transmissions differ by, let's say, less than 1% are not clinically distinguishable, and declaring one of them as the answer draws a distinction that the model cannot support. So here we propose to use optimization modeling. Optimization modeling can search the entire decision space analytically instead of enumerating every single bundle or combination of intervention, and it can find the optimal solution in seconds. Optimization modeling can also be formulated in a way to return a pool of near optimal solutions or a pool of near optimal bundles of care. For example, we can formulate the optimization problem in a way that it's going to return all of the bundles within 1% or 2% of the optimum in terms of minimum number of transmissions or minimum number of deaths. So not only we can get the optimal solution using optimization, but also we can actually obtain and identify a pool of near optimal solutions. We show that in this case study in South Africa, there are over 500,000 near optimal bundles of care. And because of the sheer size of the near optimal solutions or bundles, we are going to use machine learning to analyze and understand the structure of the near optimal bundles of care. So we developed the solutions framework. The solutions framework stands for simulation, optimization, and learning to understand trade-offs among implementable options in near optimal solution pools. The framework makes a clinically detailed microsimulation searchable and reports a characterized set of high-performing bundles. It's essentially a five-step framework. In the first step, we do a modest number of simulation runs in order to understand the decision space and the interaction and the trade-off between different interventions. But we cannot feed the output of simulation modeling directly into an optimization model. What we need to connect optimization to simulation is meta-modeling. We need to develop meta-models, ideally linear meta-models, to model the decision space. And here we develop two sets of meta models. One is called production functions that map coverage to resource use, and the other set is called benefit functions that map the coverage level to health outcomes of interest. Once we have those meta models, we can build our optimization model on those meta models. Here we develop a budget constraints optimization model, and then we solve it to get the optimal solution. And then we reframe the optimization problem as a feasibility problem in order to identify the solution pool. Again, the pool of all near optimal bundles of care that result in roughly the same number of transmissions or the same number of near-term deaths. And then we are going to analyze the solution pool using interpretable machine learning methods. So I'm going to spend some time on talking about how we apply the framework to the case study of the HIV epidemic in South Africa. Starting from the first step of the framework, namely simulation modeling. So in this research, we use the cost effectiveness of preventing AIDS complication, or the CPAC microsimulation method, to simulate the HIV epidemic in South Africa. CPAC is a validated microsimulation of HIV infection, disease, and care. We modeled three sub-cohorts in South Africa from 2024 to 2028. Those include the following sub-cohorts: adolescent girls and young women at high incidence, men who have sex with men at high incidence, and the general population aged 15 plus. We also considered 6 interventions at 5 levels each. I'm going to show you the interventions and the levels on the next slide. And then we simulated all of the possible combinations of these interventions at different levels. And that is over 15,000 combinations or bundles of care. We simulated all of the 15,000 bundles of care in CPAC so that we can compare the brute force approach against the optimization approach and see if these two approaches will match. However, the optimization method, the solutions framework that I'm going to present today, is going to only use 200 of those simulations. So we did all of the 15,000 simulations just as a validation exercise, but the solution framework that I'm going to present today only uses 200 of those simulation runs. So here are the 6 interventions and different levels that we simulated in CPAC. We had ART, testing, and PrEP. ART for the diagnosed population, we simulated 75%, 80%, 82%, 85%, and 90% coverage. The number that you see in bold is the status quo level of that intervention. HIV testing frequency for adolescent girls and young women every 1 month, 3 months, 6 months, 18 months, and 24 months. The same is for HIV testing frequency for men who have sex with men at high incidence. Testing frequency for the general population was modeled at every 24, 36, 48, 60, and 120 months. And PrEP uptake for adolescent girls and young women was modeled between 0% and 50%, and the same for MSM. In the last column, you also see the unit costs that we used in this study. Each intervention has a base cost and a scale-up cost. The base cost is the unit cost that is applied to that intervention coverage up to the status quo value. And then if we want to go above the status quo value, we have to pay the scale-up cost in addition to the base cost. And again, we simulated all of the 15,625 HIV care bundles using CPAC so that we can compare the output of the exhaustive search, the brute force approach, against the optimization approach. Now, moving to the second step of the framework, meta-modeling. Here we developed two sets of meta-models. Production functions map intervention levels to resource use. We had 6 interventions: ART coverage, HIV testing in adolescent girls and young women, HIV testing in MSM, HIV testing in general population, PrEP uptake in young women, and PrEP uptake in MSM. And then we developed 19 different production functions for resource use. Those include things like the total person years of ART and PrEP by sub-cohort, HIV tests by sub-cohort, person years of untreated HIV, and so on and so forth. So we had a total of 19 production functions to map these intervention levels to resource use. We also developed 2 benefit functions that map the same intervention levels to the outcomes of interest. Those were 5-year HIV transmissions and 5-year all-cause deaths. We use transmissions, minimizing transmissions as the primary objective, and then we also looked at minimizing 5-year deaths as a secondary objective, and I report the results of both optimization problems in a few minutes. The status quo bundle defines the budget, which was $9.2 billion over 5 years. So we fixed the budget and we asked the question of, can we optimize the allocation of this budget among different available interventions in order to minimize HIV transmissions, and as a secondary analysis to minimize all-cause deaths over the next 5 years. In terms of meta-modeling, one of the findings that we had was linear meta-models are not good enough. Because when we initially feed linear meta-models on the outputs of the CPAC simulation model, we found R-squares that looked very high. R-square for the transmission was 0.92 and R-square for death was 0.98. R-square is essentially a measure of the accuracy of the model, or how well the model fits the data. And for those of you who have a little bit of a statistical background, you probably know that these kind of R-squares are pretty high in statistical terms. When we want to do prediction or when we want to describe a pattern, R-squares about 0.92 or 0.98 are considered very high. But our finding here was that these are not good enough for optimization, because an R-square of 0.92 essentially means that the model sometimes overestimate transmissions and sometimes underestimates transmissions. What does it mean? It means that because the goal of the optimization is minimizing transmissions, the optimization model is going to explore the region where we are underfitting transmissions, and it's going to find a bundle of care in that region that results in the minimum number of transmissions. But the reason that we got into that region is because of the underfitting, not because those bundles of care actually can result in the minimum transmissions. So this is a shortfall of linear models. They cannot appropriately capture the curvature or the nonlinearity that exists, especially because of the diminishing return of more frequent HIV testing. Diminishing returns means that, for example, moving from 1 test per year to 2 tests per year finds many undiagnosed infections, but moving from 4 tests to 5 tests per year finds very few additional infections. So there is definitely diminishing benefit in the interventions, especially in testing interventions. On the right-hand side, I have included the diagram for testing frequency for adolescent girls and young women. You see that as we increase the number of tests per year, we have the diminishing benefit in terms of the 5-year transmissions. So the dashed line is what we get if we use a linear model. And the blue line, the solid line, is the piecewise linear meta model that we eventually fit. Piecewise linear only means that it's a essentially it consists of pieces of linear functions connected together to establish the piecewise linear function. So that is what we use here. And the next slide shows the R square for the piecewise linear meta models. And you see that the R square has now increased to over 0.995 for transmission and 0.999 for all-cause deaths. So now we are able to capture the output of the CPAC simulation model very appropriately using these piecewise linear meta models. And these meta models are the backbones of the optimization model that we formulate. The other question is how many simulation runs do we actually need in order to build these meta models and therefore our optimization model? Here, I show that the out of sample R square kind of plateaus above 100 simulation runs. So on the x-axis, you see the number of simulation runs used for fitting the meta models. And on the y-axis, you see the out of sample R square. And as we increase the number of simulation runs, the R square increases, but eventually plateaus. And the graph shows that above 100 simulation runs, you're essentially plateauing. More importantly, the decision quality also plateaus above 100 runs. What do I mean by decision quality? Take the best bundle the optimizer returns, and we look up what CPAC actually simulated for it. And then we compare that against the brute force optimum. And we find that above 100 simulation runs, essentially the gap between these two optimal solutions decline, and therefore we plateau after 100 runs in terms of decision quality. So in this study, we chose to use 200 simulation runs just to be on the safe side, comfortably past the plateau. 200 simulation runs is essentially 1.3% of all of the 15,000 bundles that were feasible. So I show you in a second that with only 200 simulation runs, we were able to recreate the brute force optimal solution that was needed, that needed 15,000 simulation runs. So the next three steps of the algorithm involves optimization modeling, then identifying solution pool, and then interpreting the solution pool using the machine learning algorithms. In the interest of time, I'm not going to go into the details of these methods. I just mentioned a couple of things about how we discretize our decision variables, and then I go straight to the results and start presenting the results that we found. So the first thing that I want to mention here is that if we just use continuous variables for decisions that we have, for the intervention coverages that we have, essentially we have infinite number of solutions within 1% or 2% of the optimum. So we have to discretize our decision space in order to get a finite number of bundles of care or combinations of interventions. This is how we define the ranges for each of the interventions and the steps for each of them. For example, ART coverage was modeled between 75% and 90% in the increments of a quarter of percent point. Or testing was modeled for the two high-risk groups. Testing was modeled from 0.5 tests per year, which is essentially one test every 2 years, to 12 tests per year, which is testing every month. And the step was 0.25, which means 4 tests per year. That was the step size. So using this discretizing scheme, we have over 3.1 billion candidate of bundles in this grid. But optimization is able to search the entire space in less than a second and quickly identifies the optimal solution and the near optimal bundles of care for us. The other detail that I need to point out before moving to the results is what is our definition of near optimal, right? Near optimal is kind of arbitrary. You have to decide on a tolerance level for how much how much tolerance do we have in terms of the number of transmissions from the optimum bundle? So for example, a 1% tolerance means that we are calling every bundle of care within 1% of the optimum as near optimal bundles. Here we use 2%, which essentially we said that every bundle that results in transmissions within 2% of the optimum is called near optimal bundles of care. So they are essentially clinically indistinguishable from the optimal. So 2% is within the margin of error of the simulation itself, and therefore there is no clinically significant difference between the bundle that is actually optimal versus the one that is 1% or 2% away from the optimal. How many of those bundles of care do we have here within 2% of the optimal? We have over 565,000 bundles of care in the solution pool that all result in roughly the same number of transmissions. Now, let me move to the results. Here I have the optimal bundle of care for the objective of minimizing 5-year transmissions in South Africa. We found that by reallocating the budget, we can avert over 132,000 infections over the next 5 years in South Africa. And that is a reduction of over 17%. Note that we are not using any new money. We just keep the same budget, 9.2 billions over the next 5 years, and we reallocate the budget slightly in order to achieve fewer number of transmissions. What has happened here is we have raised ART coverage from 82% to 85%. We have done more frequent testing for the 2 high-risk groups every 6 months. And we fund these two moves by cutting the general testing population to once every 10 years, essentially. So I have shown you the optimal solution on this slide, but my take-home message for you and what I want you to get from this presentation is that the optimal solution does not matter at all. It is actually misleading to look at the optimal solution. The only thing that is important on this slide is that reallocating the existing budget allows us to avert 17% of the transmissions. The optimal solution itself is just one of those 500,000 near optimal solutions that happen to have the fewest number of transmissions. But I can give you a second bundle of care that is very different from this one and still results in almost the same number of transmissions. And then I can give you a third bundle of care, which is very different from the first two, but results in the same number of transmissions, almost the same number of transmissions. So reporting only one solution as the winner, as the optimal solution, is misleading. And this is what I'm going to also show you via an example in a couple of slides. Now, the next slide shows the optimal solution for minimizing 5-year debts. The take-home message here is that by just reallocating the budget, we are not able to meaningfully reduce the 5-year debts. In order to reduce the 5-year debts, we need to increase the budget. Just reallocating the existing budget is not enough. Again, I show you the optimal solution here, but the optimal solution does not matter because, again, there are other bundles of care that are very different from this and result in the same number of deaths. So on the next slide, just to demonstrate this using a concrete example, I have listed 3 bundles of cares or 3 programs. And if you look at the number of transmissions and deaths, you see that all of these 3 programs result in almost the same number of transmissions and almost the same number of all-cause deaths. However, these 3 programs are very different from each other. The first program, Program A, spends more money on ART coverage in order to achieve 86% ART coverage, but it does not do much prep for the 2 high-risk groups. Program C, on the other hand, spends less money on ART, so it achieves 85.5% ART coverage, but it increases the PrEP uptake for both high-risk groups. For example, for MSM, it increases the PrEP uptake all the way up to 50%. Now, I hope you agree that if I only report one of these, for example, if I report program A as the optimal solution, it is very misleading because it implies that prep for MSM has to be at 0%, which is not the case at all. That is only one of the bundles of care that can result in the best number of transmissions or deaths. I can also report program C as the optimal solution. And if I do so, it is again misleading because it implies that prep for MSM should be at 50%, which is not necessarily the case. The take-home message here is that there are some components of the bundle of care that are more robust and some components of the bundle of care that are more flexible and can be set locally based on the availability and the resources available. So the next slide essentially shows the histogram of intervention levels across all of the 500,000 bundles of care that are in the near optimal solution pool. What is interesting here is that three of them, including ART coverage, testing for young women, and testing for the general population, are robust interventions in the bundle of care in the solution pool. And three of them, namely PrEP for young women, PrEP for MSM, and testing for MSM, are flexible interventions. Why do I call some of them robust and some of them flexible? Just look at the distribution of these intervention levels across the 500 bundles of care that we have in the near optimal solution pool. In all of the 500,000 bundles, ART coverage is either 84%, 85%, or 86%. So very little variation. Interestingly, if you look at the testing for general population, in all of the 500,000 bundles, the testing for general population is 0.1 test, which means one test every 10 years on average. So the near optimal solutions, they all agree on how we should do ART coverage, how we should do testing for young women, and how we should do testing for the general population. However, PrEP for young women and PrEP for MSM, as well as testing for MSM, are very flexible. For example, if you look at the histogram for PrEP for MSM, you see that some of the bundles in the solution pool use 0%, and some of them use 50% coverage for PrEP for MSM, which you also saw on the previous slide in the two examples that we had. So that is how we come up with labels for each component of the solution pool. Some of them are robust, some of them are flexible. Now, on the next slide, I'm comparing
Pooyan, can I
Yeah.
interrupt you for 3 seconds? There's a
Sure.
couple questions that I think we better address now before everything gets forgotten with the. So Nettie had a question about the non-ability to reduce death. And so she said, your comment that death does not respond to optimal solution without increasing budget. Death takes a long time. So do we know if the solution might reduce death if you look further into the future? So 10 years, 20
Absolutely.
years.
Absolutely, it does. I would say that the result that I presented for deaths is an artifact of the 5-year horizon because all of the transmissions that we avert in the next 5 years is not going to give us any benefit in terms of mortality in the near future. But if we model a longer horizon, then we will see the benefit for sure.
And I'm gonna just jump on that question as well. I was wondering when you were saying without increasing the budget, did you try increasing the budget
Yes,
and seeing and you achieved a reduction in death?
exactly.
And
Yes.
how was that achieved? Was it yeah, because I assume you didn't have additional interventions, right? You just had those same interventions, but still you managed to reduce death.
Yes, so by increasing the budget, I think I have a slide for that probably later, that by increasing the budget by like 10%, 20%, we are able to decrease the number of deaths in the next 5 years. By doing more testing in the general population, especially in the older adults, if we are able to find them and link them to care and suppress them, we are able to prevent some of the near-term deaths.
Thank you. And then Susan had a question. Do you want to? I'm realizing that I'm reading these things, but you might want to ask your question.
Sure.
Sorry.
Yeah, I may have missed this in the beginning, but all of these projections, like you start by, ART coverage is 85 to 86%, which is very good. How do you reconcile the optimal outcome with the true ground truth level of ART coverage, which maybe is 30% in some of the populations you're studying?
Yeah, so the art coverage currently in South Africa is about 82%. And then using the CPAC simulation model, we simulated scenarios for art coverage from 75% to 90%. So both lower and higher than the status quo level. And then that essentially gives us the ground truth, and the meta models that I discussed earlier are fit on the outcomes of the simulation model. And it kind of models the decision space using those piecewise linear functions that I described. But the
Okay,
ground truth essentially comes from the microsimulation model, the CPAC model.
got it. Thank you.
Awesome. Great questions. Any other questions before we continue? Okay.
There's one more.
One more? Okay.
So it's from Stephen. Do you adjust for inflation over the 5 years and increasing costs to accomplish the same care over time?
So we do not account for that. We assume that the cost of the interventions are fixed over the next 5 years. Also, we assume that our budget is fixed over the next 5 years. So I would say probably in the real world, the budget increases a little bit, but also cost of care increases a little bit. So they may cancel each other out.
Thank you. Thanks, Pooyan.
Great questions. All right, so moving to the next slide here, I'm kind of comparing the optimal solution that we find using the brute force approach versus what we find using the optimization approach. So the first column gives the optimal solution using exhaustive search, doing 15,000 simulation runs, and then looking at the solution which has the lowest number of transmissions. And then the other column is the result of only 200 simulation runs, and then fitting meta models on those 200 runs, and then doing the optimization approach. What is interesting here is that exactly those three interventions that were labeled robust based on our decision, based on our solution pool, agree with each other. And those three interventions that were labeled as flexible, they do not necessarily agree with each other when we compare these two together. And that is an important finding, because both of these quote unquote the optimal solutions result in almost the same number of transmissions. However, they try to avert transmissions in different ways. For example, the one that the optimizer found spends a little bit more money on art, but does a little less on testing for MSM and prep for MSM. So they agree on all of the robust interventions, but they disagree on all of the flexible ones. And it is reassuring to note that the one that the brute force approach found was also among one of the solutions in the top 2% solutions that we had in the solution pool. It just happens to not be the optimal bundle. So reporting either single optimum is misleading, as it would imply that the MSM split is settled while it is actually not. We have flexibility on how to spend the money on MSM prep versus MSM testing here, whereas some other components of the bundle of care are kind of robust and they should be set nationally. So analyzing and reporting the pool captures this nuance, and that is exactly what I do next. We are going to analyze the top 2% solution pool using machine learning methods. So using clustering, we found that there are 3 clusters among the 500 bundles of care that are in the solution pool. We label them as prep-led, testing-led, and treatment-led clusters. All 3 clusters share the same backbone. If you see the first column, art coverage is always between 84.7% to 85%. These are the average or the centroids of the clusters. The general testing or testing for the general population is always once every 10 years in all of the clusters. And testing for the adolescent girls and young women is always roughly every 4 months. The difference is how we spend money on MSM prep and MSM testing, because the first cluster, the prep-led cluster, spends more money on PrEP for MSM. The coverage goes all the way up to 38.1%, whereas the testing-led cluster spends more money on testing MSM every 5 weeks. And eventually, the treatment-led cluster spends less money on testing and PrEP and spends more money on increasing the ART coverage all the way up to 85%. So they differ almost entirely in how MSM budget is split between testing and PrEP. A program can pick whichever is most feasible locally. They are projected to avert essentially the same number of infections over the next 5 years. This is another another graph that tells the same story. The one that I have on the left-hand side shows the cluster centroids or averages, which are essentially the same numbers that I had on the table. And the one on the right-hand side plots all of the bundles of interventions in the near optimal solution pool on two axes, MSM PrEP and MSM testing. And you see that the bundles of care in the solution pool nicely spread across these two dimensions. The PrEP-led interventions spend more money on PrEP for MSM and less money on testing, and the testing ones spend more money on testing and less on PrEP. And also the treatment-led interventions spend less money on both of these, and obviously they spend more money on ART coverage. We also did this using a completely different approach called principal component analysis that looks at the two components that can explain the highest variation in the bundles of care in the solution pool. And we found that 91% of the variance is explained by only two interventions, which is PrEP for MSM and testing for MSM. So essentially, these two interventions explain all of the structure and the variation. The other question that might be interesting is where the money actually goes. So this slide compares how the money is spent in a status quo versus the average in the solution pool. Here you see that the category that we are cutting most is testing for general population. Maybe I can point. So here. So testing for general population has been reduced from 2.4% of the budget to only 1% of the budget. And then we spent this money in order to increase testing for adolescent girls, young women from 0.5% to 1.5%. Testing for MSM has increased from 0.04% to 0.35%. And ART coverage has also been increased a little bit as well. What is also interesting here is that the optimization or the solutions framework kind of confirms that the current program in South Africa is already very strong. We are actually moving only 1.8% of the total budget. So the 17% reduction in transmissions that I mentioned earlier can be achieved by only shifting 1.8% of the total budget. And this shift essentially is a shift out of general population testing and into ART coverage and PrEP and testing for the two high incidence groups. The other thing that we did, which is kind of interesting, is adding equity constraints to the optimization problem and then resolving it, which only takes a few seconds thanks to the power of optimization modeling. The first equity constraint that we add freezes the budget shares by population. So we said that each subgroup should keep its status quo spending, but money can move within subgroups. For example, the total money for MSM should be the same as the status quo, but we are okay with moving money from PrEP to testing or from testing to PrEP for the same subcohort. If we add this constraint to the optimization model, the best attainable transmissions is 743,000 transmissions, which is only 2.2% below the status quo. The other equity constraint that we added separately is freezing the budget shares by intervention type. So here we said that testing and PrEP should keep their status quo totals, but money can move between subcohorts. So, for example, the total money that we spend on PrEP in South Africa should stay the same, but we are okay with moving PrEP from young women to MSM or from MSM to young women, right? If we add this equity constraint, the best attainable bundle achieves 647,000 transmissions, which is about 15% lower than the status quo. So this is very interesting. Freezing budget by intervention type is fine. We can still achieve the majority of the transmissions benefit, but freezing the budget by population, by sub-cohort, is hurting us a lot because, as you see, we only achieve 2% lower transmissions. So why is that? Because the most important budget shift is moving money from general population testing into key population testing. So that is why that is a within type move. And therefore, if we are okay with keeping the same money within the same type of interventions and just moving the money between sub-cohorts, that is a better equity constraint to include, and that still results in 15% reduction in the total transmissions in South Africa using the same money, no new money, right? So our final policy statements for the program manager in South Africa are as follows. Number one, do not expand general population testing. Every near optimal bundle holds it at the floor of once every 10 years. Second statement is that we need to raise ART coverage to about 84% to 86%. Then testing for adolescent girls and young women at high incidence should be about every 6 months. We need to aim for PrEP for young women uptake of about 10%, which is close to the current level in the status quo, but we should not expand it beyond 28%. And the last statement is that we can decide the testing and PrEP mix for men who have sex with men locally, keeping testing at twice a year or more, and such a mix costs at most 0.4% of the optimal transmission counts. Essentially, that is the most flexible part of the optimal bundle of care. You can mix testing and PrEP for MSM in different ways and still achieve the same number of transmissions. I mean, the worst mix is only 0.4% worse than the optimal, which is essentially nothing. So that decision can be set locally based on the availability and acceptability, but things like ARC coverage, testing for general population, and testing for young women, those are the more robust parts of the solution pool, and therefore they need to be set nationally. So, summary and conclusions: reducing the incidence of HIV requires combining several interventions at the right levels in the right populations under limited budgets. Microsimulation models evaluate a small set of strategies and report the best one, but they cannot search for a better one. We built the solutions framework to make microsimulation models searchable using the power of optimization modeling and machine learning. There is no single best HIV bundle of interventions, and searching for one asks the wrong question. Many different bundles perform close to the optimum, and what matters is the backbone they share, namely the robust and the flexible parts of the bundle, which our framework helps to identify. With that being said, I want to thank you all for listening to my presentation, and I'm happy to take any further questions.
Thank you, Pooyan. That was such a beautiful presentation. It was so clear, and your slides are wonderful. I see Susan is ready to go.
Yep. So great presentation. Thank you. This, I don't even know how to structure this question, but basically, what does the fund flow of money, HIV related, look like in South Africa compared to, for instance, the United States? So yes, there's a federal budget for, HIV prevention, but that money then gets allocated to the states, and the states are completely different in how they prioritize the resource allocation. And I guess my question is, how do you control for any level of mixed penetration of whatever the resource is in a particular community? Or it's just these are the targets, go for them?
Yeah, that's a very good question. My understanding is that there is more flexibility in South Africa about how we can spend our budget. I know in the
Okay.
US there are restrictions of this money can only be used
Yeah,
for
yeah.
PrEP or this money can only be used for that. My understanding is that there is less restrictions on how to spend the money in South Africa. But the good news is that any restriction that exists is only one additional constraint in the optimization model.
Yeah.
We can easily add that to the optimization model and solve it within seconds, and then come up with new solution pools and then analyze them.
Got it.
So
Okay.
these are additional scenario analysis that we can actually do and add to the paper. So thank you so much for the feedback.
Yeah.
Thank you, Pooyan. I'm going to ask a question while other people think about theirs. You talked about the equity considerations, and that led me to think that was equity in terms of the total, kind of number of transmissions averted. I was wondering if you had considered also overlapping another optimization scenario in which you consider equity in terms of health disparities. So, like the HIV burden in specific populations, so that you would decrease HIV incidence disparities among, for example, men who have sex with men or among young women. Is that something that you have considered?
At this time, I have not considered that, but that can also be added to the optimization as an additional scenario analysis. What I have done, which I didn't present today, but it's in the appendix of the paper that I'm writing, is assuming that no intervention can be cut compared to a status quo. Obviously, if the budget is also the same, we cannot do anything because the current budget is already fully kind of allocated, right? But if we keep all of the interventions at the current level and then we have some new budget, maybe 2% more, 5% more, how can we allocate that budget among the existing interventions without cutting any intervention below the status quo level? So that is an additional scenario analysis that we have performed that I didn't present today, which is a little bit different from what you kind of described, but kind of along the same lines.
Great. Yeah, I was kind of thinking of the PrEP to need ratio in which you allocate PrEP based on need in certain populations, but also this kind of whole health economics movement to prioritize equity and reduce health disparities above other kind of general population outcomes. I see Tim has his mic unmuted.
Thank you. A couple of things. To build on what Anik said, I'm just wondering if the infections averted, if you have characteristics of the populations where the infections were averted. So were they in adolescent women or were they in MSM? And that might give you some sense of if your solutions are prioritizing one population's health needs over another.
Very good question. I
Kind of
think
interesting to think about. But
yeah, go ahead, and then I will answer. Okay, so let me answer this part of the question. I think this is a great idea because I know that the CPAC microstimulation model is able to capture exactly among which subpopulation those transmissions were averted. The data that I had for this project does not specify that, unfortunately. So the meta models that I have built for feeding to the optimization model just estimate the total number of transmissions averted. It is not stratified by the subcohort. But I believe this is something that we can definitely do in CPAC, and therefore we can do subcohort specific meta modeling, and then we can add that to the optimization model and do the type of equity analysis that you mentioned as well. So this is something that we can certainly do in the future, but unfortunately the current analysis does not cover that.
Can you maybe talk about how you would apply these methods to similar problems, but domestically?
Yeah, for sure. So for a new setting, we need to identify the interventions and the subcohorts. For example, more recently, we have started working on an analysis in Massachusetts. So the subcohorts there are different, people who inject drugs, MSM, and then different interventions for these subcohorts. So first, we need to define the interventions, the subcohorts, as well as the levels that we want to include in our simulation and therefore in our optimization model. And once we do that, we do a modest number of simulation runs, maybe about 100 to 200, and then we feed meta models on the outputs of the simulation, and that gives us all of the ingredients that we need for building the optimization model, creating the solution pool, and then analyzing the solution pool using machine learning methods. So essentially, for a new setting, the thing that will be different, I would say, is the subpopulations, the available interventions. Maybe we want to include long-acting PrEP, for example, or long-acting ART, and then doing new simulation runs and creating new benefit and overlap functions. But I would say the algorithm, the framework is very generalizable, not only to HIV in other settings, but even to other infectious diseases like tuberculosis or COVID-19. So whenever you have a bunch of interventions that are competing against each other for a limited budget, we can essentially apply the same framework to identify the characteristics of all of the near optimal bundles of care.
Thank you, Pooyan. And I'm going to read you the question from, she had two questions. And the first one, I think we were all probably very surprised by the huge proportion of the budget that is allocated to ART. And she was asking if you had evaluated any scenarios in which ART drug costs decrease. I don't know if South Africa has an agreement with or is using generics, or if there would be any way to decrease those ART costs, and is that something that modeling could be used for to kind of push for a decrease in ART costs?
Yeah, exactly. So the good news is that the cost of each intervention, both the base cost and the scale-up cost, are just parameters in the optimization model, are just numbers. So we can easily change that number and put a lower number and then resolve the optimization model in seconds, and then come up with new solution pools and analyze them. So that can definitely be done, but at this time, we fixed the cost based on the status quo and the current numbers. So we did not look at what happens if the cost of interventions will be lower or higher in the future.
And do you know if they have a good, cheap cost for ART, like has happened in many countries? Or is it relatively high in South Africa because they're not a low-income country?
The numbers that
it's a mix, right? It's a mix. I mean, the public sector is all generic ART, but there, it's a pretty robust private health system, which probably has more options for ART. But like, for example, there's dolutegravir, TDF, 3TC or whatever, that's the standard. But what if they went to dolutegravir 3TC that instead and lowered the cost of drugs by like 25%? That would have a huge impact, for example, and that could kind of modeling could kind of help understand how that might help with coverage and overall costs and free up money for other interventions.
Thank you. I'm aware it's 9, so for everybody that needs to run to clinic or anything, thank you so much for coming, and I'll stay around if anybody has other questions. I don't know if you can stay, Pooyan, or if you have a meeting, but just wanted to thank you because it's been such an interesting presentation, and thanks everybody for coming.
Yeah. Great presentation. That's all I wanted to say. Great.
Thank you so much.
Thanks. Bye.
I just wanted to acknowledge that Lily had another question, which was accounting for how feasible it is to implement some of those scenarios. Like, for example, the testing every 5 weeks for men who have sex with men, right? So I guess you could overlap another optimization, kind of algorithm to identify which are most feasible.
Yeah, definitely. So in terms of the cost, we did increase the additional cost of increasing the levels of these interventions beyond the status quo, both in terms of testing and in terms of ART coverage. But we essentially defined a range for each of these interventions that we thought are feasible in the real world to implement. Uh, so if we think that, for example, 5-week testing for MSM is not really feasible in the real world, we can easily add that as an additional constraint to the optimization and solve the problem. But for now, we assume that testing for MSM can be done between like every like 1 month to every 24 months. And we did assume that there is an increased cost of testing if we want to do it more frequently than every 18 months, which is the current status quo level.
Great. And I just wanted to read you a thank you note from Nettie, who said, great talk. And it is heartening to see that there are so many ways to succeed that could be applied based on setting. And thank you for explaining the complexity so clearly.
Thank you so much.
Thank you so much, Pooyan. This was so interesting and a great way to close this week. And I'm very glad this talk is recorded for anybody who couldn't make it today. And Lily also says, thank you so much.
Thank you so much for inviting me. It was a pleasure to give a presentation to this audience, and I also learned a lot from the questions that people ask.
I have many others, so I might email you, but they were more technical, so they were going to be boring. And people had lots of questions as well. So thanks so much, and have a nice end of the week.
Thank you so much. Have a good weekend, everyone.
Bye.
Bye.